This is my lovely Egypt. Knowing is not enough, we must apply. Willing is not enough, we must do. Gotha, second. My agenda today, we will speak about anatomy and physiology of peripheral nerves, pathology of nerve damage, types of neuropathy, approach to case of peripheral neuropathy, recommended nerve conduction and EMG protocol in peripheral neuropathy, and lastly, some special types, which is very important, of peripheral neuropathy. To understand the pathology, we have first to know something about anatomy. Acquire like this. This is the axons in the middle covered by myelin. In matter of fact, the myelin doesn't cover all the nerve. There is area along the nerve not covered by myelin, which is node of Ranvier, and it is very important for the transmission of action potential. This is the Schwann cells, which is responsible for the formation of myelin. This is the axon, and this is the myelin. As we see, this is area which is not covered by myelin, node of Ranvier, which is responsible for the transmission of action potential by the saltatory movement, saltatory conduction. That's fast conduction. That's why the myelinated nerve fiber has a fast conduction velocity rather than the unmyelinated. The nerve fiber diameter may be large or small, may be myelinated or unmyelinated. The transmission of impulses according to the type of nerve. Is it motor, or sensory, or autonomic? The motor impulses transmitted along large nerve fiber, large myelinated, called A fiber. This is the motor. Regarding the sensory, we have myelinated, large myelinated, thinly myelinated, and unmyelinated. The large myelinated, which is A alpha, responsible for the deep sensation, which is touch, vibration, and so on. Whether the thinly myelinated, which is the E delta, responsible for cold perception, and the unmyelinated responsible for warm perception. That's why the large myelinated, which is the target of of nerve conduction study, transmit the sensation of the deep sensation. Okay, and the autonomic by thinly myelinated and fibers. Okay, what is going on if there is any disease of the nerve? What is the pathological process produced? This is the normal nerve, cell body, axons, and the myelin. If there is injury to nerve, first there will be Wallerian degeneration, which is degeneration starting from the injury to the periphery. This is Wallerian degeneration, and it takes time to occur. Second is segmental demyelination, where there is destruction of myelin around the nerve. And the last one, the third, is axonal degeneration, where there is destruction of the axon. When there is destruction of the axon, the degeneration occurs proximally, what we say dying back. This is axonal degeneration. What is meant by peripheral neuropathy? Neuro means nerve, apathy means sickness. That's simply to say it is damage or injury or disease of the nervous system, whatever the cause. The disease of the nerve may impair any function of the nerve, maybe motor, sensory, autonomic, according to the fiber affected in peripheral neuropathy. What is the type of neuropathy? The neuropathy may be mononeuropathy, where just one nerve is affected, either by entrapment, either by injury, whatever the cause, just injury to one nerve, this is mononeuropathy. If there is more than one nerve in more than one limb, it is called mononeuropathy multiplex, like here. One nerve, two nerve, more than one nerve in more than one limb. Plexopathy, there is affection of the plexus, and that's why the whole limb is affected. That is my target today, polyneuropathy. Polyneuropathy, it is bilateral symmetrical affection of both upper and lower limbs distally. Affects long nerve first. That's why it affects lower limb first and then extend to upper limb. How we can deal with a case of peripheral neuropathy? Of course, clinical is important part in our exam. You cannot do new physiology without clinical of the patient. So we have to history, exam, and investigation. History, according to the type of fibers affected. And the affection may be by increasing or decreasing, what we call positive symptoms. It's very important because positive symptoms usually is present in acquired cases, while negative symptoms is present in hereditary causes. In case of motor, the positive symptoms, fasciculation, cramps, myokemia, whatsoever, and loss of function, wasting, weakness, hyperreflexia, hypotonia, and so on. Regarding the sensory, the positive symptoms, dysesthesia, paresthesia, allodonia, whatever symptoms, and the negative symptoms is decrease or loss the pain, temperature, and deep sensation, vibration, proprioceptive, and so on. And as I said, I mentioned, the negative or positive symptoms is important because if the patient coming complaining of positive symptoms, I have tingling, numbness, pain, whatsoever, this is usually acquired neuropathy. I mean, it's treatable. This is the pattern of weakness if the polyneuropathy is motor, affect the motor fiber. The pattern of weakness is bilateral, as we said, bilateral, symmetrical, affecting lower limb as affect long nerve first, lower limb more than upper limb, distal more than proximal, and extensor more than flexor. If it affects sensory, the patient coming complaining of glove and stalking hypoesthesia. The patient wear glove and stalking. This area, there is diminished sensation or lost sensation. Above this area, the sensation may be nearly normal. What is the investigation to case on peripheral neuropathy? Of course, you have first to diagnose this is a case of peripheral neuropathy. And that is the important rule of EMG and nerve conduction. It has to diagnose this is a case of peripheral neuropathy. The other investigation to search for the cause of peripheral neuropathy to treat either lab or nerve biopsy to diagnose and treat the case. What is the goals of EMG? Why I ask for EMG and nerve conduction peripheral neuropathy? Just to tell me this is a case of peripheral neuropathy? No, no, it is more than that. First, as we mentioned, the EMG and nerve conduction is the tool of investigation of lower motor. That's why he will tell us where is the lesion. Is it anterior cells? Is it nerve? Is it neuromuscular junction or muscle? Okay, in case of peripheral neuropathy, he will tell us that this is a nerve. This is number one. He will tell us, is it the nerve, which type or which distribution? Is it reticulopathy, mononeuropathy, or peripheral neuropathy, what we want? This is first question. Second, he will tell us which type of fiber affected. Is it motor? Is it sensory? It is combined sensory and motor. And this is very important to clinician to diagnose. Third, the severity of lesion. Yes, he can tell us about the severity of lesion. If it is excitable nerve at all, this is a severe form, and so on. The nature of underlying nerve pathology, which is very important, as we mentioned before, this is axonal or demyelinating, the injury in the axon or in the myelin. In demyelinating, I can differentiate if it is hereditary or acquired. In case of axonal, I can give an idea about degeneration. All of this, nerve conduction, the EMG can answer all these questions. That's why I always told Janius, if you have a case referred from a clinician, why it is a peripheral neuropathy. He doesn't want to hear from you that this is a case of peripheral neuropathy. No, he wants you to explain all of this. You have to tell him all of this to make him the diagnosis easier, and he can diagnose and treat. So in case of peripheral neuropathy, we have 5 Ds. 5 Ds I have to answer: the facet, distribution, disease pathology, duration, and developmental and drugs. Distribution, as we said, is it mononeuropathy multiplex, or polyneuropathy? The deficit, is it motor, sensory, autonomic? It's very important because we have sometimes or subtypes of peripheral neuropathy is purely motor, like GBS. GBS is common. It is fatal by respiratory arrest, despite it's treatable. That's why it's very important to be diagnosed. When you said it is a motor peripheral neuropathy, so the clinician, if he suspects that GBS, he will be confirmed by this. It is plus diphtheric, porphyric, this is something or some causes which cause motor neuropathy. If I said it is sensory, the most famous example here in Egypt is diabetic, because it's famous. Diabetic neuropathy is mainly sensory, in addition to alcoholic, in addition to arsenic, to libretic, and so on. So it's very important to tell doctor, is it motor or sensory or combination by motor, sensory, or autonomic. Duration is very important regarding, as we said, the impact. It may be acute, less than 1 month, subacute from 1 month to 3, or chronic. The most common is hereditary. Acute is GBS, duration below 1 month or less than 1 month, and CIDP, chronic inflammatory demyelinating polyneuropathy, may be subacute or chronic. And I am afraid to say that CIDP is underdiagnosed. I saw many cases which is CIDP and misdiagnosed. And the chronic, which means CIDP or more chronic, which is hereditary motor sensory neuropathy. Pathology. The pathology, as we said, normal, maybe axonal degeneration, maybe demyelinating. To understand axonal and demyelinating and how we differentiate between both, this is something which is difficult, so please concentrate with me. When we apply stimulus and we have the response, from application of the stimulus to get the response, this is what we call latency. Latency and the conduction velocity is time dependent. That's why it is affected in case of demyelination, because it is responsible for transmission. This is the amplitude. From baseline, this is the amplitude. Amplitude number of nerve fibers. So it depends on the axons. That's why in axonal neuropathy, it will decrease. Okay? To diagnose demyelinating neuropathy, we have criteria must be present. At least 3 of the following 4. 3. First one, distal latency must be more than 130% of upper limit of normal. Second, conduction velocity must be reduced more than 75% of lowest normal. Third, prolonged or absent F waves. In addition, we may find conduction block and temporal dispersion. This will explain in the section to differentiate between hereditary and acquired. This is the criteria to diagnose demyelinating neuropathy. Okay. According to the site of demyelination, the parameter of the nerve conduction will result. This is, imagine this is median nerve, and this is the stimulus in the wrist, and this is in the elbow. If there is demyelination distally, like here, if I apply the stimulus here, the distal latency will prolong it. But because there is no demyelination here, the conduction velocity will be normal. But in case of F wave, as you know, F wave is late response. The stimulus from here transmits proximally along the nerve and return once more. That's why he will pass this affected area. That's why F wave will prolong. This is if the case is distal demyelination. If the demyelination is proximally, let's to see. If the stimulus is distally here, distal latency will be normal because there is no demyelination here. Conduction velocity will be normal because there is no demyelination here. But if I perform F wave from here to here, it will transmit this area of abnormality and F wave will be prolonged. That's why F wave is very sensitive for demyelination. The first example, we have demyelination here, here, and there. So if you perform a stimulus at the wrist, there is prolonged distal latency. In the elbow, there is decreased the conduction velocity, and F wave also is prolonged. That's why the parameter of demyelination is depending upon the site of affection of demyelination. What about axonal loss? Axonal loss, the axon is responsible for the amplitude. That's why if there is reduction or axonal affection, there will be reduction of the amplitude. But diagnostic criteria to diagnose this is axonal, it must be the conduction velocity never decrease more than 75% of the lowest normal, and distal latency never then prolonged more than 130% to differentiate between axonal and demyelinating. And why we differentiate between both? Because axonal degeneration followed by demyelination, and demyelination followed by axonal degeneration. That's why it is important to determine which is thought first. How can I assess the axonal loss? The axonal loss can be determined by 2-3 things. First, the previous baseline values. If I have to the patient a previous value, I can determine if there is axonal loss. And that's why I admire Professor Dr. N, who said that the patient after injury coming to me in the first 3 days, I perform conduction velocity to get the baseline data of the patient. It was so excellent, I admire it. It's very important to have the baseline data to the patient to detect if there is axonal loss. The second, I can compare from normal data we know. We know that the amplitude of median is 4, amplitude of 1 or 6. That's why if the amplitude reduced from this, I can say this is axonal loss. This is axonal neuropathy. This is the second method. The third is contralateral side. Sometimes in unilateral patient, when the patient coming complain of unilateral side, it's very important to perform the normal side, to compare right and left. This is the mistakes we did in the beginning of our work. We start to, the patient complain of right side of, for example, ulnar, and we found the amplitude is 6. This is normal. 6, 7, 8, this is normal. So we said it's normal. But when we perform the contralateral side, we find it 18. That means the conduction, that the amplitude reduced more than 50% of the normal side. So it is axonal degeneration. And this is what we missed in the beginning of it. That's why to assess axonal loss, we have 3 methods to detect. So axonal degeneration or axonal neuropathy, there is a reduction of amplitude. Demyelination, there is prolonged distal latency and decreased conduction velocity. This is a normal. This is the demyelinating. You see, this is the distal latency, it's prolonged. But in axonal, it just decreases. The same in distal latency, but the amplitude is reduced. Sometimes it's very difficult to differentiate between axonal and demyelination, which is taught first. Sometimes, in cases especially in borderline. They try to solve this problem by how we perform the nerve motor action potential and picked up from muscle distally and proximally. The most famous example is common peroneal nerve. The common peroneal nerve could be assessed in the external digitorum brevis here distally and stimulus neck of fibula and here, and tibialis anterior, which is proximal from tibialis anterior. We assess common peroneal at the neck of fibula and behind the neck, lateral to external hamstring tendon. We perform here and there and compare conduction velocity from both sides. In normal condition, conduction velocity equal in both tests. In case of demyelination, it is nearly equal. But in case of axonal, we found the conduction velocity is smaller in the distal part. That's to differentiate between axonal and demyelinated in borderline cases. The last question is hereditary and acquired. It's very important because acquired is treatable, you can treat, but hereditary, you can't treat. As we mentioned, positive symptoms raise the possibility of acquired. How we can differentiate, this is a great disease, it can cause peripheral neuropathy. How we can differentiate between acquired and hereditary? In case of demyelination, it is easy, by conduction block and temporal dispersion. The presence of conduction block and temporal dispersion raise the possibility of acquired neuropathy. What is meant by conduction block? As you see, this is the distal and this is the proximal. The amplitude decreased markedly. Temporal dispersion, duration, it is increased proximal. Like this. This is CIDP. The distal is normal, but when you ascend proximally, the amplitude reduced and the duration increased. This is a conduction block, partial conduction block, and temporal dispersion. Like this. This is a distal, this is a proximal. The amplitude reduced and the duration increased. What is the explanation? Temporal dispersion, this is the normal response, the normal nerve. All the impulses reach at the same time, and there's augmentation, and the action potential will be more. But in case of demyelination, of course, distally, it is short distance. It is not easy to appear. But in proximal stimulation, it is long nerve. That's why, as you enrace long, rapid, fast conduction and slow conduction, it will act. Instead of augment together, no, it will cancel together to produce temporal dispersion. Like this. This is augmented together and they form what it is. But here, in case of positive phase of fast, it is in the opposite side positive of slow. So they will cancel each other, and that's why we reduce temporal dispersion of the nerve. To say conduction block partial must exceed more than 50%. This is definite more than 50% reduction in amplitude. Temporal dispersion more than 150. This to explain. Okay, this is example. This is our normal nerve conduction, distal and proximal. And this is the hereditary. You can see it is the same figure, completely the same, but the parameter is different. You find here distal latency 3, here it is 12.7. Conduction velocity here is 559, here it is 12. That's to say, in hereditary, the same figure of normal, but parameter is different. But in acquired, you see like this, it is disfigured. We have conduction block, we have temporal dispersion, despite the parameter the same. So we found the parameter the same as hereditary, but there is disfigurement, not like the normal. That is the difference between hereditary and acquired. And this is, of course, the axonal reduction of the amplitude. This is normal, this is hereditary, the same figure, but the parameter is different. And this is acquired CIDP, and you see this, there is this figure. Don't forget drugs, because it's common. I saw some cases of drug and cause neuropathy. Usually axonal, usually drugs axonal. Some exception, but usually most of drugs cause axonal neuropathy. Okay. I had a case of peripheral neuropathy referred from a doctor. What should I do? What is my protocol to perform nerve conduction and EMG for this case? I hear and I forget. I see and I remember. I do and I understand. In the doing is the learning. You have to do. You have to perform by yourself to learn more about nerve conduction and EMG. It is learning. Why do we? The protocol starting for nerve conduction for peripheral neuropathy is as we'll see. First, you start by lower limb because nerve conduction, peripheral neuropathy affecting low nerve affect lower limb before upper. So we start by the lower limb. This is the common peroneal and extensor digitorum brevis by 3 stimulus sites. After I perform the motor of common peroneal, this stimulus must be reversed to perform F-wave. I have to perform motor common peroneal and I have to perform F-wave. This is posterior tibial naviculus, just down in posterior, just 1 centimeter, abductor hallucis longus, and the stimulus behind the internal malleolus, medial malleolus, here, and the other behind the knee. After I perform motor of posterior tibial, I have to reverse the stimulus, the cathode, inwards to perform the F wave. Then I have to perform sensory of the lower limb. This is sure behind lateral malleolus and 14 centimeter start stimulus behind the leg. And this is superficial peroneal, midway between tendon of the tibialis anterior and lateral malleolus, midway. This is the active toad and the passive 2 fingers below, and about 12 centimeter stimulus bilateral. This is superficial. After I finish one side, I have to perform at least 1 motor and 1 sensory of the other side to compare symmetry of the nerves. Then I ascend to upper limb. I have in one side before, this is the median nerve, ductus pulsus brevis, stimulus at the wrist, here between both tendons of flexocardialis and palmaris longus. This is the stimulus distally and proximally over the brachial nerve, the brachial artery, medial to it. This is the medial nerve, motor. After I finish, as I said, this stimulus is reversed. Cathode become in to perform FLVs. This is the ulnar nerve. I have to perform ulnar nerve at abductor digiti minimi, and this is in the junction between the hand and fingers. And this is stimulus at the wrist, lateral to palmaris longus, and here in the medial epicondyle, 3 centimeter below, and above knee, I have to measure 10 centimeter. It must be 10 centimeter to perform accurate measurement. This is the ulnar, and after I finish the ulnar, as we said, we reverse the stimulus to perform F-wave. Then I perform median sensory in the fingers and ulnar and the 5th finger sensory. And after I finish, I have to perform 1 nerve motor and sensory to the other side to assess symmetry. This is our protocol for nerve conduction for upper control. Sometimes I have to perform radial sensory in the snuff box. Why to perform radial sensory? I have a problem in case of axonal neuropathy of lower limb in certain situations. There may be axonal neuropathy and I couldn't decide. Like what? Like young people. Young people sometimes show a nerve amplitude is large, maybe 30. If he had axonal neuropathy and the amplitude decreased to 20 to 15, this is still above the normal value. So I couldn't discover if there is axonal neuropathy. Second situation is the old people. The old people, there is normally the amplitude of the visual nerve will decrease, maybe 5. This is borderline without axonal neuropathy. This is normal. So I couldn't find this low amplitude for aging or it is axonal neuropathy. I couldn't know. Third is obese people, because the fat or adipose tissue separated, insulating between the stimulus and the nerve. That's why maybe the amplitude is not accurate. That's why we perform the ratio between visual nerve and the radial nerve. This percentage of comparison between both, if it is exceed 0.2, it means that it is axonal neuropathy. Because as we said, peripheral nerve affects lower limb first. What about EMG? As we said, peripheral neuropathy is distal. That's why I have to perform EMG distal. Of course, EMG in axonal, because in demyelinating, we just find decrease of movement. It's not big things. But in axonal, it's very important. Sometimes I find EMG finding before the production of nerve conduction. I have to perform EMG distal. That's why one person said I have to perform in the foot muscle of fitness. No, we don't prefer foot muscle. Why? First, it is very painful to the patient. Second, the patient cannot move the muscle accurately and so cannot assess motor potential exactly. Third, this site, which is foot, is repeated or exposed to repeated trauma. That's why normally I can find some of neuropathic changes. That's why we don't prefer the foot muscle to EMG in axonal neuropathy. We do what? We perform extensor hallucis longus. This muscle, it's about 4 fingers above the ankle, just lateral to tibialis anterior tendon. Of course, it actually the big to ask the patient to do tibialis anterior. I guess all of us perform tibialis anterior. This is 2/3 and 1/3 just lateral to tibial crest. Gastrocnemius medial pad, the medial posterior cuff. Vastus medialis and the gluteus medius, I perform to exclude. It is not because peripheral neuropathy is a peripheral. This is a proximal muscle. Usually, it's not affected in peripheral neuropathy except if there is dermatoma lesion. It is polyradiculopathy if there is a radical beside peripheral neuropathy. But usually in peripheral neuropathy, it is not affected. Upper limb distally. First, dorsal interosseous, midway between thumb and index. Biceps femoris, biceps brachial, sorry. Extensor epiphysis populus is 4 centimeters above styloid process, ulnar process, sorry, above. Pronator teres flexor cardi radialis, it's preferred, but unfortunately I couldn't find the picture for this. This is deltoid, as we said, to exclude the peripheral neuropathy, because as we said, peripheral neuropathy is a distal, so the proximal muscle should not be affected. We found spontaneous, this is axonal, not demyelinating in axonal. We found spontaneous activity, fibrillation or positive shock waves. Motor unit potential of the neuropathic, it's neuropathic. It's polyphasic, long duration, large amplitude. This is of neuropathy. And incomplete interference pattern is recruitment. This is what? Of neuropathic, neurogenic. This is neurogenic. Large, this is a normal. Large amplitude, long duration, incomplete interference. Okay. Now we will discuss some important types of polyneuropathy, which we will face with it. Important as it is treatable, important because it is common and you will face today. The first is Guillain-Barré syndrome. Guillain-Barré or GBS. it's common. It's life-saving because the patient, if it's not diagnosed and returned to home, may die from respiratory arrest. It is treatable. That's why it is very important. GBS is autoimmune. It is acute monophasic immune-mediated polyneuropathy. This is Landry, Guillain-Barré, Stroll, who discussed or mentioned Guillain-Barré. The problem in Guillain-Barré immune-mediated is the similarity between the gene of the virus and the protein of the virus and protein of the nerve. The myelin covers the nerve. That's why the immune system attacks our protein with fixation of complement and destruction of myelin. That is the normal, as we see, and this is destruction, which we call myelin in case of GBS. This is the immune attack here with complement fixation and destruction, as we see through myelin, destruction of myelin. Sometimes maybe axonal motor. Axonal motor because it attacks nodes of Ranvier, which there is no myelin. Nodes of Ranvier and Wallerian degeneration and production of axonal degeneration. It's type of GBS, which is axonal and motor. The stages of GBS usually febrile stage, influenza-like attack or gastroenteritis. And then symptoms disappear and the patient starts to complain of tetraparesis of acute onset, less than 1 month, proximal, and maybe cranial nerve affection. It must have areflexia. From diagnostic criteria for GBS, areflexia must be present. This is the types, variant. Classic is demyelinating. You have demyelinating polyneuropathy with temporal dispersion, with partial conduction block. It's classic demyelination. This is the classic form of GBS. But we found axonal motor, we found the acute motor sensory axonal neuropathy. Of course, the prognosis of demyelinating is better than demyelinating. Prognosis is somewhat good, better than the axonal. Miller-Fisher ataxia, agitaxia, reflex tunnel maybe by sensory. I found, I saw 2 or 3 cases, just sensory. And sometimes GBS return. I found 2 or 3 cases, GBS and acute, and return once more. Diagnosis of GBS, as we said, clinical, what we said, EMG, nerve conduction, as we said, demyelinating, this is a classic form. Don't forget CSF because there is cytoalbuminous dissociation, which is confirms the diagnosis of GBS. What is the problem in GBS? The problem in GBS is the early. Sometimes the case is referred to you in the first 3, 4, 5 days. In the first days, the nerve conduction study may be completely normal in case of GBS. This is the problem. That's why I myself perform usually H-reflex and F-wave to all GBS because early, maybe the conduction study is completely normal and the only abnormality found is by F-wave and H-reflex. That's why I performed it routinely to all GBS. Second is, I myself in the report, I mentioned normal conduction study is not against GBS in first week because the treatment is plasma exchange. And if you said it is normal EMG, is normal nerve conduction, he had problem to treat. That's why I said it is normal, not against GBS, and you have to return it after 2 weeks. Sensory neuropathy or sensory of GBS, sensory for GBS and CIDP has a characteristic, something special to them, which is Shural scale. This is opposite what we said. There is affection of median, ulnar sensory, and when you perform Shural, you find it normal. This is something special to GBS and CIDP. Chronic inflammatory demyelinating polyneuropathy, this is the chronic form of GBS, exactly the same. Similarity between both is, first, they are polyradiculoneuropathy. Number 2, demyelinating neuropathy. Number 3, they have multifocal prevenous inflammatory infiltrations. That's similarity. What is the difference? Of course, time. GBS is acute, less than 1 month. CIDP is subacute or chronic from month to 6. Number 2, CIDP from the beginning is asymmetric and affecting upper limb. This is something special to CIDP. And it is responded to corticosteroid. A big difference between GPS not responding to corticosteroid, but CIDP, corticosteroid is the treatment of choice in addition to IVIG or plasma exchange. The phase of or the prognosis of CIDP 3-3-3. Third cases, monophasic, slowly progressive. Third cases, stepwise and progressive. And the third is relapsing remitting. CIDP, unfortunately, underdiagnosed. I saw many cases. Went to different doctors. CIDP is not in their minds. That's why it needs diagnosis. The variant as it is demyelinating, maybe axonal, distal sensory, with diabetes, with hypertrophic nerves, and so on. What I have to say is multifocal demyelinating neuropathy with conduction block. It was considered a part of or subtypes of CIDP, but nowadays they separate it as a different entity. These types of CIDP. They differ it as a different entity because it is purely motor, it is affecting more upper limb, and we have more conduction block at places, not usual place of entrapment. So you can find the conduction block at more proximal, at axilla, iris, and so on. This is the diagnostic criteria. As we said, it is progressive, focal, asymmetric limb, and no sensory abnormalities. Okay. This is the conduction block. To diagnose conduction block, as we said, we have definite and probable. Definite, more than 50% reduction in amplitude. This is definite conduction block. Probable, just 30% reduction. Sometimes we couldn't find conduction block, but it is said it is multifocal with conduction block. But sometimes I saw some cases, very difficult to find this conduction block. You have to perform so many times, so many nerves, so many sites to attach the conduction block. Diabetic neurosis are very, very common in imaging, and diabetes can produce any form of neuropathy because it affects the vascular, affects the lipid-rich the content of the myelin, nutritional due to deficiency, and so on. So diabetes perform or produce neuropathy anytime. Maybe mononeuropathy, reticulopathy, autonomic, symmetrical polyneuropathy, and CIDP, very common. Mononeuropathy, any nerve, median, ulnar, sciatic, nerve, sex, any nerve can be affected. Diabetic amyotrophy, this is a proximal. By the way, diabetic is sensory. The patients coming complaining of motor, think of two things. Think it is CIDP, or it may be diabetic amyotrophy, affection of motor proximal. The patient cannot withstand after sensory symptoms. This is the sensory motor polyneuropathy of the diabetes. It's predominantly sensory, affecting lower limb, more decreased pain and temperature, sensory ataxia, and so on. This is classic sensory motor polyneuropathy of diabetes. What is the problem in diabetes? As we see, the EMG, the nerve conduction, assess the large fiber. That's why if the diabetes affect the small fiber, the nerve conduction will be. We find the cases complaining of burning sensation and due to sensation found memory. This is because it is more fiber. The routine, as I said, the routine nerve conduction couldn't detect the abnormalities. So our limitation nerve conduction EMG just in small fibers affection. This is the only limitation to nerve conduction study in polyneuropathy. Of course, hereditary, not treatable. When you said to patients you are hereditary, it is disappointing because you were handicapped. Charcot-Marie-Tooth is the most common. It's many types according to the chromosome and the gene. Autosomal dominant, selective, recessive, all types of genetic. What is problem in hereditary. There is gene responsible production of protein involved of structures of either myelin or axon. This gene defect, that's why there is defect in production of nerve of axon or myelin with production of this hereditary. Of course, as we said, either demyelinated or axon. In case of demyelinating, you found the same figure of normal, but the parameter is different. And the last negative symptoms is the predominant, not positive symptoms. This is the heritage. So you have to say, lastly, the electrodiagnostic studies are supplementary and not replacement history that we have. Sometimes doctors, not all doctors knows what they want. They said, refer this case to you in general college. Doesn't tell you what he wants. So you have to listen to the patient and know what to do. History is very important. Even in the books, textbooks of neurophysiology mention usually the clinical. It's very important. Electrodiagnostic result is often time dependent. It takes 4 times, and you have to take all patients the time required for diagnosis. Third, electrodiagnostic study are not standardized investigation. So the practitioner have to answer the diagnostic questions in every case. So take your time from what you want to the patient to diagnose the patient. You have to help the clinician to diagnose the patient, especially in treated cases, because he will cure. Lastly, I want to say, the more I read, the more I acquire, the more certain I am that I know nothing. I always advise the generation that they must read all the time, listen to the lectures all the time, because science is tell the deaf, you have to learn more and more and more.